Today is the launch of a project that Gail and I have been working on since we figured out 2002. So this has been a long process, and I'm really delighted to share our work with you today. My name is Cinda Rushton. I am the Bunting Professor of Clinical Ethics in the Bourbon Institute and the School of Nursing. And today we're going to share with you some work that we've been doing on the integration of pediatric palliative care into chronic diseases. And today we're going to focus on, in particular, the case of Duchenne Muscular Dystrophy. This is a project that Gail Geller, who you'll meet in just a moment, who's a professor in the School of Medicine at the Bourbon Institute, have been working on. We have had many rounds of support from different sources, starting with the Stavros Niarchos Foundation, the Greenwell Foundation, Sylvian Foundation, and a funding from the NIH with one of the challenge grants through NINR. And so this is really the culmination of all of that work. Whoops. So the sort of focus of our work has been to look at the practices and principles of pediatric palliative care and to explore how they might be applicable to young people with chronic diseases like Duchenne Muscular Dystrophy. And when we began our work, the field of palliative care was really developing and evolving. And when we started, the model was one that looked at the care of people, regardless of the length of their life, from the point of view of quality of life, how we could support them in their choices and decision-making, how we could help them to navigate the often complex ethical questions that they face, and also to focus on how to make their lives as good as they could be for as long as possible. And so hope has always been an important dimension of living with chronic illness, and also to think about the transitions that most people go through in life, and in particular with chronic diseases, from, you know, sometimes a up and down course to one where they're actually facing the end of their life, and with that, the bereavement process. As we began to do this work, the thinking in the field actually began to evolve. And one of our wonderful colleagues, Ross Hayes, who is a pediatric palliative care specialist in Washington, began to talk about the integration of palliative care from the time of diagnosis. And that concept is really important as we think about young people who have chronic life-limiting conditions, and the role of palliative care as they are progressing in their disease process that can go along in tandem with curative treatment, but that is integrated really from the beginning and the time of diagnosis. And our work really took this model and began to look at chronic diseases like Duchenne Muscular Dystrophy, where we know that there is a disease trajectory, where there are many opportunities where palliative care principles and practices can make a difference. And importantly, we didn't think of bereavement as just at the end of life, but actually starting from the time of diagnosis, and that's something that our families have talked a lot about, and I'm sure Joe will share with us a little bit later, is that actually grief and loss begins when the diagnosis is made. This work has been reinforced yet again with the recent release of the IOM report focusing on death in America, although not focused specifically on pediatrics. It reinforces many of the underlying principles and areas of opportunity that we addressed in this project over these many years. The idea of focusing on person-centered, family-oriented care, which in pediatrics is absolutely essential. The gaps in clinician communication and advanced care planning, and in a moment we'll talk about this project actually began with exploring the questions around advanced care planning with teens with muscular dystrophy as sort of the beginning of our inquiry into this area. The huge gaps in professional education and development, and one of the contributions that this curriculum makes is that it is an innovative, experiential, multimedia curriculum for interprofessional training to look at how to actually integrate those practices and principles into daily care. The IOM report also, importantly, I highlighted the gaps in policies and payment systems and the need for public education and engagement to improve care for all people, not just young people, but certainly relevant to our population as well. And just to highlight the sort of trajectory of our own work, the first paper that was written, Lori Irby and Gail and I participated in a qualitative study exploring these questions of advanced care planning. And one of the themes that came up as we began to talk with young people and their parents about when would it be appropriate to think about palliative care, one of the themes was, my son is still walking. And for many parents, as long as their child was actually ambulatory, they didn't really see that the questions that often came up around palliative care were relevant. And so from that, we really began to look more specifically at some of the opportunities across the disease trajectory for palliative care integration. And you'll see a later paper there where we actually tried to map what the trajectory of illness is and where the opportunities might be for palliative care integration. So with that as kind of a backdrop for why are we talking about this in the first place, we saw that there were great opportunities to improve the lives of these young people by using palliative care principles. And Gil Geller, who I mentioned as my co-collaborator, is going to talk about some additional work that we did surveying clinicians.
So thanks, Cinda, and thanks to you all for being here. What we really want to call your attention to, this, Cinda mentioned at the beginning that this is an unusual seminar. After we finish our little 5-minute spiel each, we're going to show you a film that we developed as part of this curriculum, and then we're going to have a panel discussion with Joe Rivers and Dr. Tom Crawford, who you will see in the film. But before we do that, I just want to present a little bit of the data that we collected along the way. We conducted a number of empirical projects along the way related to this overall goal. One of the projects that we did, which was funded by the Greenwald Foundation, was a national survey of multidisciplinary pediatric neuromuscular clinicians. So physicians and nurses and various kinds of physical therapists, occupational therapists, social workers, all kinds of allied health professionals. And we wanted to know what they thought about the appropriateness of incorporating palliative care into the care of children with Duchenne muscular dystrophy. And this is just a little bit of a summary of some of the data that we obtained from the clinicians. We asked them a number of questions about their attitudes and then their reported practices. The first attitude is palliative care is primarily about providing care at the end of life. This goes directly to what Cinda was just describing as our aim of incorporating palliative care earlier and earlier and earlier in the trajectory of disease, ideally from the time of diagnosis. So we wanted to see where clinicians really landed on this point. So 41% agreed with that statement, that is most relevant at the end of life. We had an attitude item, referring a child or adolescent to palliative care services too early will undermine the family's hope. About 15% agreed with that. That's not as bad, perhaps, as we thought it might be, but we still have some work to do in that regard. And then we gave people a question about, when they thought palliative care ought to begin, at diagnosis, during treatment and follow-up, or at the end of life. And here you see the breakdown of responses to that. A pretty small percentage of clinicians thought it was appropriate to include palliative care at the time of diagnosis. We then asked about reported practices. Have you ever called an ethics consult regarding a child with a neuromuscular disorder? About a quarter of respondents said they had, and about a half of respondents, which again was better than we might have anticipated, said that they had called a palliative care consult regarding a child with a neuromuscular disorder. But again, it's not 100%. I think we still have some work to do with regard to changing attitudes about the relevance and appropriateness of palliative care among these clinicians. And this is just sort of what are some of the factors that influence the likelihood of calling a palliative care consult. And as you can see, palliative care consults are least likely to be called by nurses. We might talk about that a little bit later. And most likely, not surprisingly, to be called by people who believe that palliative care should begin at the end of life. So there is generally some resistance to including palliative care earlier and earlier in the development of this disease. So this is some qualitative work that we collected with support from the Stavros Niarchos Foundation in probably 2003. Jo Rivers reminded me that her son Ben, who drew these drawings, was 8 years old at the time that he participated in this study. As many of you know who work with children, one of the best ways of learning what their attitudes and beliefs and experiences are like is through drawing. We worked with a child life specialist to help us interpret some of these drawings. And so we asked Ben, at the time, we didn't know he and his family would become major stars in our ongoing work. But at the time, Ben participated in the study. He was 8, and we asked him to draw a picture of himself now. And as you can see, he drew a picture of himself in a wheelchair. The wheelchair is very, very small relative to other modes of transportation in the picture. There's a large truck, there's a bus much larger than his wheelchair. And there are dark clouds overhead. There is a little bit of sun peeking through, but a lot of dark clouds. And then we asked him to draw a picture of himself in 5 years. And this is what he drew. He's standing tall. He is, in fact, taller than a building next to him. And the black clouds are disappearing. So I can ask you what your interpretation of this drawing might be. Most of us assumed that this was a drawing about hope for a cure, that in 5 years he'd be standing tall and walking and running and, sort of just like he should be. And we were wrong. We were dead wrong. When Ben was interviewed, and again his mother will probably refer to this, when we interviewed him and asked him to explain his drawings, he said, well, I really believe in reincarnation. And when I die and when I'm reincarnated, I will be reincarnated as somebody who could walk. So this was a huge lesson for us in the assumptions that we make about hope, what people hope for, what people know and understand, first of all, as early as the age of 8, and what people hope for. And hope for a cure is not necessarily highest on the list of children and families living with this condition. So it's something to file in the back of our minds as we watch this film, which we're going to show you next. This is a series of films that were developed by our Academy Award-winning filmmaker, Nigel Noble, and his stellar crew. We developed 6 or 7 short videos that were embedded in this curriculum that we're launching today as triggers for conversation. So we're going to show the film called On the Edge, and then we'll invite Joe and Tom up for a panel discussion. So, no.
The arrow. Yeah.
This? Okay. This is too easy. Is that it?
Okay.
The transition for Ben into the wheelchair, permanently in the wheelchair, was mixed. I was happy for him because he was happy, but I was sad. I was sad that every time I looked at him, I knew what was going to happen in the future.
Duchenne dystrophy is relentlessly progressive. We expect things to be lost at every increment of time. Something has to be given away, and that's part of the tragedy of this disease.
The last year has been very interesting for this family. Ben got very sick and ended up in the intensive care unit at Johns Hopkins for 7 weeks. Because he came home from school, it was at the beginning of October, came home from school complaining that he'd got a bad tummy. It wasn't long after he started vomiting that he was throwing up this horrible, I'd never seen anything like it. As I'm washing my hands, I looked over to him, and the boy's lips were turning blue. I couldn't believe it. I'm like, are you okay? Well, he just couldn't say anything, he couldn't breathe. I got the chair up, I grabbed the phone, and I had to call 911.
We didn't know at the time that he'd lost most of the use of his right lung from fluid and collapse. So that made it even more critical. We didn't even know that, but we knew this was not like any other episode with him.
I wanted Dr. Crawford involved, and that doctor in the emergency room did. He called and spoke. And they decided that they would send a helicopter down for Ben, that this was valid.
They recognized he was in extremis and needed to get there quick, and an ambulance wasn't the right choice.
At some point, I'm in the room with Ben, and he's like in and out. He's just not well. And I said to him, and I yelled at him, I said, "Are you leaving me? Ben, are you leaving me now?" And he actually opened his eyes and he goes, "No, Mum, I'm not leaving you."
I thought he was gonna die and didn't want that to happen. So I couldn't really sleep that night that he went to the hospital, even though I was with my friend and she was trying to keep my mind off of the subject.
There was no room in the helicopter for either his mother or I, and his mother would have gone.
And there's my boy, he's gone. I don't know if I'm gonna see him again. Probably not, okay? We get in the car, Tim and I, and we're driving up to Baltimore, which is a 2.5-hour trip.
It's a quiet, dark, 2 a.m. drive.
Tim and I never said a word to each other. It was like we were just lost in our own thoughts.
It's tough to let your mind wander too much when you're thinking about things like the death of your own son or his survivability, and it is easy to let the thoughts wander to, okay, how are you going to react? And you try to think, okay, well, will it be easier without him or harder without him? And even in times when the routine gets tough, especially when I'm overworked and lack of sleep and the routine gets too hard to bear, and I think I'd be happier if it was over and I didn't have to do it. And then I realized what that means for me not to have to do it. The alternative is worse. And it doesn't really seem that hard anymore to put up with it. And so every day is okay if I got to do another day. Because the alternative, which will happen someday, and I'll have to deal with it, I'd rather be as far off in the future as possible. I drove her up to the hospital front door and dropped her off. I said, go check on him, I'll go park the car. There was a period of time it was a big question in our minds whether we'd see him again.
Ben's parents were not ready for this. They were scared. I don't think you can ever prepare somebody for having your child throw up blood and look deathly ill. There's no such thing as preparing just for that.
When a child arrives in the intensive care unit, I think the staff feel helpless as to how to quickly develop a relationship with the family.
Every shift brought in the ICU brought a different nurse, a different therapist, a different team of doctors, and we needed some continuity. And the continuity was us as the parents tracking his progress and knowing what worked and what didn't work, and reminding the doctors and nurses what worked and what didn't work.
I was being told one thing by pulmonary, I was being told gastro's thing, pain management were involved at one point, wound care were in because Ben got a bed sore within 2 days of being in the ICU.
Healthcare providers were shocked at his weight and how thin he was, but really were more shocked that the healthcare providers had not been speaking to the family prior to that. Now, having said that, none of us had any idea of what had been said in clinics and prior to Ben arriving to the PICU. So it's very possible that those conversations were taking place, but we weren't aware of that. But still, we had a reaction.
Nothing was off his plate, and for whatever he wanted he could eat. Trying to gain weight and high protein diets, high protein drinks and weight gaining drinks and stuff like that. But unfortunately, he didn't like a lot of the tastes and textures and didn't have an appetite, that he just didn't eat enough to gain weight. So it was always a concern.
I really want you to try and eat all of that, okay? That's important.
And we resisted Dr. Crawford's initial recommendations to start a direct stomach feed.
Samples in the fridge.
Because we didn't want
put
to
it on the leash
put him under another operation after a couple of major operations for his legs and his back. So we resisted that.
I'm not going to torture kids with too much stuff in order to restore or sustain some more minor function further into the future. This is the balance that I think a clinician has to make. Is what are the discomforts and what burdens am I going to place on his life now in order to sustain what functions and abilities later on? And is the juice worth the squeeze? What are the places where these things can, where's the balance made most properly?
And I kind of resisted it because I didn't want to go to that next level yet of care, and I didn't think he needed to be tied to that kind of feeding, so I resisted that recommendation. But to be down to 55 pounds now and near death, we were open to, of course, any suggestions.
In retrospect, I wish I had done the G-tube before the event. It would have been really nice to have had it in when he didn't need it. But I know that Mom and Dad were not ready for that, and Ben was definitely not ready for that. The only way that I was going to move them along to the point where they saw that as a benefit, to say, look, Ben, I've seen other guys like you, and they all like this after it's done. But ultimately, it's consent, and he has to buy in to say that I agree with you. When he reaches the legal age of consent, I would very much pay attention to what his desires are and what he wants.
I would speak up and say something about it. It would be nice to actually be involved in something that has to do with me, because I know more about my body than anyone else does.
Early on in his course, I had suggested that perhaps he would benefit from seeing a behavioral psychologist who has special expertise in helping children cope with the challenges of chronic illness. The feeling was that it would be more of a stress because of the number of relationships that he was being asked to develop. Several weeks into his course, though, it was actually brought back up by his mother.
The big discussion was getting Ben to take his focus off of the machines that were constantly monitoring him and place it elsewhere.
The thing I was looking at was my oxygen levels, because I remember I passed out at one time because they weren't really paying attention to the oxygen numbers. I just felt like I couldn't trust anyone. That I thought I was the only one that could help myself.
So who was in charge from a medical perspective? The ICU attending is the person in charge.
Informed choices. But nonetheless, we know those choices are coming along, and how do I help people with those sorts of things? And so my hope is that as we go forward, the opportunities that are presented by Duchenne dystrophy, of course, I want to do much better than that. I want to make them better and not have to go through this progress at all. But in addition to those hopes, I'm hoping that we can use the opportunities of this disease to sort of understand better these questions about how do we help people choose and understand things that are unknowable on its face. Leave it there.
I actually would like to ask you a question, Tom.
She does this, didn't it?
No, I want to know what it was like for you to know that Ben decided to forego the trig.
So, I just heard that. I want to make certain that the decision was made based on the correct information, but on the other hand, what is correct information in that situation? He was told it's a possibility that he wouldn't be able to communicate normally with the trach, and that is certainly the case. I don't know the probabilities of it, but on the other hand, I know about decisions that are made in the future, and sometimes people get closer and closer to decisions and they make different decisions. So I'm not going to lock him down to any decision that he makes now just based upon that fact that he chose once not wanting to be living like that. It may well be that as things come along, he might be willing to change the decision. And I'm going to work with him and roll with those punches as they go.
And I actually have one question for you, Joe, before we open it up, which has nothing to do with palliative care. I just would love to know what it was like for you and your family to participate in this project. To be filmed, to expose yourselves.
It was a free therapy session. It was very therapeutic. And the fact that it might be helpful to future families coming in. You know, the ICU stay, that family meeting was invaluable. I mean, that was like having an IEP meeting at school. But I can see how things can be contentious, because things become contentious and then the meeting can happen, or there's a lot of confusion and then that meeting happens. I think that needs to be done a lot earlier so that you're all on the same page. You know, as a parent coming in to the ICU, I've still got normal life stuff going on. I'd lost 3 of my family members in England, boom, 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 one after the other. Tim was losing his job, and I'd got a teenage girl who was going through her own stuff. So that, and then this with Ben. So my emotions were running high anyway. I don't think I misbehaved or anything like that to the staff, but, you know, and they were getting, there were a lot of things going, right? I wasn't, was I? Yeah, discussions about
Tom beat Joe, Joe beat Tom.
There's one other dimension about Duchenne dystrophy that's not brought up by this, because Bren's a very bright guy, very self-aware and knows where he is. But a lot of guys with Duchenne dystrophy have a graded level of cognitive impairment. And one of the things that's particular in pediatrics that I am increasingly interested in is how do people establish a sense of who they are, who they themselves are. The normal progression of life is that, you know, moms hold that baby tight and say, no one will ever come between me and my baby. And they're going to fight off every attempt to try to separate, but not maybe always aware of the fact that the kid's going to start pounding their way out, saying, let me go. First, you know, let me run away and watch me, mom, watch me, mom. And then later on that evolves to, you know, give me the car keys and I want a bigger allowance. And that normal process of letting your kids go is painful for all parents, because we didn't expect it from there. We expected, or we were trying to defend it from outside. Problem with Duchenne dystrophy is just when the kids are starting to feel like they want to get further away, the world starts to feel increasingly perilous. So a boy with Duchenne dystrophy who's sitting on the edge of my exam table, if he leans forward 1.5 inches one way or the other, he's going to fall off and whap his head on the floor and have a concussion. The height of an exam table feels like you and I would feel sitting on the edge of a skyscraper. It's really scary. And so the world feels increasingly perilous at a time when normally kids would be pushing themselves away. As a consequence, I see a lot of times when I ask, this happened this morning, I asked a kid with Duchenne dystrophy, what do you want about this or that? And the first thing he does is look at mom. And this is a teenager, and it's like, what, this would not be the normal response of a teenager to ask mom's forgiveness or what do we think about this or that. And so sometimes I wonder whether or not when we ask, what do you want, that actually is itself a little bit of a cruel hit, because it's not the right way to be thinking about the way to help the whole family or the whole together. This is a dimension that I don't think we've explored enough. And in Ben's case, it's not the case because he's very independent. And sometimes it is and sometimes it isn't. How do I measure that?
So we wanted to open it up to you now to ask questions of our panel. Insights, questions.
I don't need it. Thank you. Yaron Uber of the Berman Institute, thank you. So I'm a pediatric hematologist oncologist, and I wonder, Dr. Crawford, how is working with Joe and Ben, or Ben and Joe, pick your poison, who you want to put first in the relationship, how has that changed your day-to-day relationship as you approach other kids and families? Because I imagine that you take a little bit of each patient and it kind of forms, but it seems like you have a very excellent relationship, and I can imagine that that's good and bad. I wonder if you've been able to pick any pieces apart of how that has changed how you go about your day-to-day clinical life.
That's a really hard question. And I went into child neurology initially to care for kids with a disease that was even worse than Duchenne, if that could be, a disease in which we always lost, Wernicke disease, SA1. And I have to say that I knew going into it that I was going to be a specialist in playing a losing hand. And I'm delighted that that's no longer the case, because we have some incredibly good prospects for improving the life of all of the disorders I'm caring for. That's just a huge bonus. But I feel personally that I get something from these guys. And I am, in the case of Joe and others, I feel privileged to work with heroes. You can see it in this movie, but also day in, day out, I get to be present when when moms and dads do extraordinary things. And that is that's a huge gift to me. And I know we're playing a losing hand, and yet it feels good to be there, even though I don't want to be. It's weird. It's perverse in a strange way, but it works for me. And that's who I am.
Yaron's question, I think, is a really important one. In our curriculum, we included one of the modules focuses on the angst of healers and some of the emotional and ethical challenges that are sort of embedded in the roles to engage clinicians in exploring that very question, because we know that those are very much intertwined, how we are as clinicians and how it influences the care that we provide. So, it's a great question. Others, yes?
Hi, Holly Taylor, also from Berman Institute.
Just hold it closer.
Hold it closer?
Yeah.
Holly Taylor, Berman Institute as well. So given your conversation, I think I appreciate that transitioning to the trach could be radically life-changing, but it's not as clear to me as maybe you can make it in terms of, I assume it needs to lose so much of his sort of mobility and ability to interact with people on a daily basis, and if you wouldn't mind just sort of sharing what's the most important thing for him in that decision.
Is that a question for you?
For both of you, the technical.
You do the trach thing.
Many young men with trachs find that the difference, so that as they lose things, and the trach actually is the ability to gain something back. So I know that the issue of living, he imagines what life is going to be like in the trach right now, and I get how he feels that would be something he doesn't want to exist as, and I completely agree with him on that point. There might be a time, though, when the trach actually represents an improvement from where he is. And so this is this technical issue. And boy, what does informed consent mean in that situation? That's much more complicated than I am smart. We'll muddle our way through.
But I guess just, again, technically clarify it means that he has to have a machine that's helping him breathe.
Oh, yeah. So the point is, yes, he will have to have he will have to, now he's using a sip and puff ventilator right now, which involves him actually voluntarily thinking about every breath, which is a lot of work. He's in a motorized chair that is, it's like a mobile ICU. It does so many things. Adding a ventilator to the back of it that's attached to the tracheostomy, as opposed to what it is right now, is no additional encumbrance. It does require some actual suctioning and all those kind of technical things. But he's worried about whether he can be able to speak. It is absolutely the case that when he has a trach, he'll be unable to speak in longer sentences, but he might actually be able to speak better than he is right now. But again, we can't push these things too fast.
Well, for Ben, when the pulmonologist said, you know, a tracheostomy would extend your life for many years, possibly, he did say, though, that you could end up having more hospital visits, you might be open to more infections. And he did say, because of your weakened state, that the talking, because they have to learn how to talk and push that air. So his pulmonologist said that there may be a chance that you might not be able to speak through it. So just the thought that there's a chance that he would lose something else, it was just too much for him. And he said, no, I just don't want to do that. And you're right, he might change his mind. But for now, he's staying true. He is under hospice care at home. So we have all the palliative care there and the nurses and stuff coming in. And he's kind of relieved that he doesn't have to be going to his doctor's office quite so much. And it kind of relieves a strain. Well, so, not that that's an insult to you. But he doesn't have as many doctor visits, let's just say that. You know, he can pick and choose, which he's more comfortable with. So that a quality of life thing right there. He gets to sleep in longer, and because he gets worn out. He's very tired, so.
So I just want to comment on this dialogue for those of us in the clinical arena who try to help people think about these kinds of complicated questions. There aren't easy answers. And it really does depend on where you sit and how you think about quality of life, what gives life meaning, what those boundaries are. And this is really the crux, I think, of some of the ethical challenges of how do we balance benefit and burden? How do we take account of Ben's perspective and his family's perspective and what's possible from a technology point of view? And it's not one answer. And so I think part of what we're hoping in this curriculum is that these films will engage us all in what does that process need to look like? How do we engage in the conversation? Some of the fears we have may be our own fears, and that the people we're trying to serve would really benefit from conversations that we're not able to have with them. So, other questions?
I'd love to know also what you all thought of the film. What?
So, I just wanted to ask, thank you very much for allowing us to see your family like this. One of the things that I was thinking about was you know, you had talked, Dr. Crawford, about in some ways the certainty of this disease, but there's also a lot of uncertainty, right? In the video, you were in the ICU and wondering if that was the last day, and now we're years beyond and talking about maybe a trach, maybe more years, who knows? And when I work with families in similar kinds of circumstances, I struggle to know how to help them manage the uncertainty and still be very present in the everyday and still get the quality of life out of every day. And so I wonder if you have anything to share about, you know, my instinct from you, my sense from you, the way that I saw you in the video and the way I see you now is that you are quite present in the here and now with your son. And I wonder what helps you to stay there, and are there things that we as healthcare providers can do to help your family be in that place?
Well, that is an interesting question. For me, I can only focus on one day at a time, because I can wake up in the morning and know what my day's going to bring, and then, no, everything changes. So you've got to be patient and kind of easygoing at the thought that something could change just at the drop of a hat. Focus on the day, and that's all I can do. And just stay positive, really, and hopeful that the day doesn't bring anything tragic. But we live in a way that it's like anticipatory grief constant. You always know at the back of your mind that something is going to happen. We know what is going to happen. We just don't know when. And there's the insecurity. So you just do it. There's really no right answer to that, to be honest. But support the families that you're working with is basically, I would say, a good piece of advice. Get that?
First off, Joe's one of my heroes, of which I have the opportunity to meet many. One of the things about the practice of medicine, I think all of us feel, is this issue of multiple non-intersecting dimensions. There's the issue of the technical aspects of the disease, and the technical aspects of the various different therapies that we might bring to apply to them, and their relative burdens and benefits and costs and stuff. And then there's the insurance company that will or won't pay for it. And then there's the doctors that will or will not be cooperative in helping with doing this or that I want them to do. And then there's the logistics of getting them here. And then there's the fact that one family member wants one thing, another family member wants another one. And we work in this, part of what being a physician is, ask your doctor, you know, like we're supposed to know. But there's 15 different things that are all intersecting, and there isn't a single solution to that sometimes. Sometimes the best solution we think is over here, but the next best is something way over there. And I think it's a privilege to be able to work in that kind of space where we don't get to have the right answer, we just keep trying to nudge it in the right direction. And when you get to work with extraordinary people, it feels good. That's kind of where I'm at.
I actually want to ask a question too. It is related to this idea of uncertainty, which is of great interest to me. I'm sure you all noticed that Ben was extremely thin when he was first admitted to the hospital and gained a lot of weight after the G-tube. Joe, you said that you wanted to say something about how, you know, as certain things improve, other things.
Yeah. For every treatment that we do to improve quality of life, there's like a repercussion further down the line. So you're constantly dealing with, you know, Ben presents a challenge, and you learn to live with that challenge or overcome the challenge. When you overcome it, you're only going to deal with it further down the line and have to overcome that one or work with that one. So for the huge doses of prednisone that Ben did to keep him walking and keep him out of the wheelchair for all those years, then we were dealing with soft bones and bone issues and having to drive and do the IV treatments and things like that, which affected his surgeries because he had screws and plates put in and stuff. And then, you know, okay, so we've got the G-tube. It's great. Oh my gosh, he's got a belly like butter. But I'm the one that has to lift him every day. So it's like, you know, the lesser, you know, so you're dealing with that, yeah. So there's always something.
Other questions?
Hi,
Hi, Joe. I'm Ted Bailey from the Berman Institute. And I wanted to thank you and your family for giving us this window onto all these aspects of the experience you've had that we wouldn't otherwise see. One of the moments in that experience was this, looked like a light bulb moment where you realized that you could call a family meeting. And it was this sort of hidden right, hidden power that seemed like it was of great value to you that you didn't know about. And I was wondering, as you've gone through all this with your family, are there other, if you could invent healthcare, as reinvent it from the ground up, are there other kinds of services or powers or rights or things like that that would seem particularly empowering? So we always talk about biomedical innovations, but are there innovations in healthcare that seem like they would help you even more? Things along the lines of like being able to call a family meeting.
I think if you're going to be going for a long hospital stay, okay, and I think once you're admitted into the intensive care unit with a major illness like that, it's going to be obvious you're going to be there a while. I think if someone, I don't know, like a brochure that says how to in the ICU, and all the rules and regulations that are there, one person at a time, take away the confusion. That's one less thing you have to wonder about. I think that would be even helpful. There are do's and don'ts about the ICU. There's rules and regulations, there's laws, the things that, privacy and things. Your new centre here, though, the new ICU here, is fabulous because the rooms are individual. We were over when it was the old building, and so we were sharing a room with one or two other children and having to deal with that privacy and things like that. So for me, it would be, let me know how this is supposed to work. Talk to me, tell me what to expect. Just be upfront. That's, I think, is important. Take away confusion.
I actually would just like to add to that obviously in your perhaps unusual case, maybe not at Hopkins, you're 2.5 hours away.
Yes.
And the reality was that Joe and Tim were never together because somebody had to be at home with Megan. So, and then of course Megan's whole reaction. So it seems like there's a lot that we can do better with respect to just family well-being.
But I think some of that confusion was ours too, though, because I remember this oscillation, there was not one opinion about the way that things go forward. Maybe when you call, I don't remember this, but maybe when you call the family meeting, it was time to say, okay guys, let's pull this together, because the initial parts of it were fragmented and very good ideas that were not always in the same direction. It wasn't clear who was going to be, that if we had gotten together, there would have been a single spot. So what I would like to say is I'd like to be able to communicate our confusion rather than feel like everything has to be coherent, because it clearly wasn't and couldn't have been until we knew more.
Joan Pettit, School of Public Health, IRB. I'm interested in this issue of your child as he got older and the question of informed consent. You had a young boy, you made all the decisions, and then somewhere along the line, some of that responsibility shifted to him. And once they turn 18, and they really shift. So I'm interested from both your perspectives on how you make decisions if informed consent is challenging enough already with a child who reaches majority while he's under your care.
Okay, well for Ben, for us it was a case of when Ben could start to say to me, I don't want this, and I use 2 words to both of my children anytime, and that's convince me. If they can convince me why they want something or be able to do something or not do something, if they can articulate, then they're ready to accept their decision. And so for Ben it was 3rd grade, and it was the decision to stop the steroids. And he told me that, and I said, convince me. He said, I don't like how they make me feel. I said, explain. And he felt angry, and he felt like people didn't like him because if they made him behave badly. So with that, we went to Dr. Crawford, and he said, okay, I'll back you up, but you understand, Ben, don't you, that you won't be walking, you'll be in a wheelchair. And that's where it started with him. I always would reword what the doctors were saying to him in a way that he could understand. I always brought up an example of, remember how you felt when you went into your wheelchair? That's how you're going to feel by taking the sip and puff. So you can do that. Now, when he turned 18, he actually signed the power of attorney for me to be able to speak for him, but with him there and him making the ultimate decision. So that's how we handled it.
Talk about informed consent. That's how I wish we could teach that to lots of folks, because that would be ideal, not always attainable. I'll see your question and add to it. Recently had a young man with Duchenne dystrophy who was, I think, 23, 24 years old, who was intellectually subnormal. He liked his life being able to watch TV. Mom told me, I'm tired. I can't do it anymore. I've spent nothing but the last 25 years of my life doing this, and I just can't. He tells me he wants to be on a ventilator so he can keep his life as it is now. And Mom's saying, I can't. And the question to me is, who's not consenting here? I mean, if we just do him, it's one thing, but I have to be mindful of that Mom, who is selfless and wonderful and generous and says, I've got nothing left. I still haven't figured that one out. So I think that because of the nature of Duchenne dystrophy, we have some very complicated interactions, and it's just not one thing. I'll probably come to a ethics committee meeting on that one.
So we're out of time for today, and just want to thank Joe and Tom both for being here and sharing their experiences, and really for all the people who participated in this incredible project, the clinicians, the families who let us come and film in their homes, and all the other people who have helped us to get this together. Meredith for putting this all on the web. Today does launch our curriculum. It is available for download. The films are open access as well as the curriculum. And we really invite you to use these films to advance our work and to engage in conversations that will lead us into, inevitably, some of these really important ethical questions. And so thank you for being here today, and let's thank our